Hello, friends. Let's continue with anemia and pregnancy, part two. Today, I'll be talking mainly on the management of anemia. Let's not waste time. Let's straight away jump into the management. As I told yesterday, management is influenced by the cause of anemia. Obviously, if it is iron deficiency anemia, you better give iron. But if it is not, then giving iron can be detrimental to the patient. Suppose it is beta thalassemia, iron is dangerous. Type of anemia, of course, whether it is microcytic, hyperchromic, macrocytic, hyperchromic, the treatment is totally different, isn't it? And if iron deficiency anemia, then of course the gestational age matters because whether to give oral iron or whether to give the injectable ions or whether to straight away go for PRBC. So gestational age matters. If the gestational age is advanced, then of course we don't have time. So we have to straight away go for PRBC or maybe injectables. Whereas if the gestation is early, then we have a lot of time for oral iron therapy. Severity again matters irrespective of gestational age. Suppose, let's say she's early gestational age, but the severe anemia, 4 gram percent, then you can't be hoping her to, recover with oral iron only. Maybe initially we have to give 1 or 2 PRBCs and then switch over to oral iron. Associated complicating factors. For example, as I told you, if there is urinary tract infection or if there's infestation, unless you treat that, iron is not going to be absorbed or iron is not going to be helpful. It's called refractory anemia. So this is a very important slide in the management. You have to write this first, then only it shows your maturity in treating. Simply don't write about iron and PRBC. So factors influencing, you have to write. So management of iron deficiency anemia, ideally hospitalize the patient, especially if if the hemoglobin is moderate to severe degree. General treatment, of course, goes without saying diet, which is rich in iron, but a lack of phytates. And you have to add maybe vitamin C and other things, the green leafy vegetables or citrus fruits and things like that. Improve appetite and digestion, that is a general management. Treat infection, as I already told many times, you have to treat simultaneous infections, whether it is UTI, malaria, or hookworm infestations. Treat the cause, that is the worm. Now comes the main point, whether to give iron or PRBC. I already gave you a hint how to decide on that, but this is a detailed slide with a table. If it is mild anemia, iron should be good enough. Whereas if it is moderate to severe, depending upon the situation, PRBC is a must. Usually what we say, if the hemoglobin is less than 8, then only it's a threshold for PRBC. If it is between 8 to 11, we can still manage with iron therapy, which is away from term. As I already said, if it is early pregnancy, then we have a lot of time for slowly recovering, giving oral iron. Whereas if it is near term, there's no time to recovery. So PRBC is better. No hemorrhage. So then iron is okay. But if the anemia is due to hemorrhage, you have to compensate immediately because that will take otherwise a long time, whether it is APH, PPH, or later maybe PPH. No refractory anemia. So then iron is okay. But if there is a refractory anemia, then PRBC is better to immediate recovery. No infection. Again, iron is okay with that, but infection is present. You have to give PRBCs that will fight the infection. It will help fight the infection along with the antibiotics. And then, of course, you can switch over to iron therapy. So now let's come to how to give the oral iron therapy, having decided to give iron therapy. It is 60 milligram elemental iron. I have told you this many times. 60 milligram elemental iron, only 6 milligram is absorbed. As a prophylaxis, 1 tablet per day is enough. But here we are talking about the treatment or therapy. So the same tablet has to be given 2 to 3 times a day till hemoglobin normalizes. Taking one time itself is difficult, so I wonder whether the patients will take 2 to 3 times. Maybe you have to consider elemental iron straight away through the injectables. But anyway, if the patient is compliant or refusing the injectables, then 2 to 3 times a day she has to take. But of course, when you give 3 times, then we have to time the calcium in a separate time. Continue prophylactic dose till 3 months postpartum or end of lactation. In fact, now we are seeing 6 months, in anemia Mukt Bharat. If patient develops gastric intolerance, ferrous ascorbate or carbonyl iron may be tried. And nowadays we have the slow releasing tablets, which will release only in the duodenum. What are the drawbacks of iron therapy, oral iron therapy? Intolerance, of course, that's the main thing. Unpredicted absorption, that is, in spite of patient taking normally and she doesn't have intolerance. Side effects, that's the reason why the patients will discontinue gastritis and constipation. What are the contraindications? Are there any contraindications for oral therapy? Of course, intolerance is the main contraindication and severe type near term, near 40 weeks. It's not exactly contraindication. It is foolish to give iron therapy when the anemia is severe and near term. Better to go for PRBC. Evidence of response, how do you know that it is responding? Sense of well-being. Patient, it takes, of course, 2 to 3 weeks minimum, 3 weeks. Then, of course, there will be a rise in hemoglobin, hematocrit returning to normal, and we will see reticulocytes in the peripheral square. These are basics. All of us know about that. Rate of improvement, it is evident in 3 weeks, as I said already, and it is 0.7 gram per DL per week. That's a slow improvement. Why is that? Even though, you give all the iron, whether in the oral form or in the, of course, oral form, you can't give all the iron. Even in injectably, the body has certain capacity to produce the heme per day. So even if you give more, it will be just kept in the stores. Something like, if the tailor can stitch a shirt, 5 shirts a day, and per shirt it is 2 meters of cloth. If you give 10 meters, he will stitch 5 shirts. If you give 20 meters, 10 meters he will keep in the store because his capacity is only 5 shirts per day. Somewhat like that. So the rate of improvement is almost similar whether you give oral iron or whether it is injectable iron. It is 0.7, maybe injectable is slightly better. Parenteral iron therapy, what I mean by injectable, indications are intolerance to oral or unreliable for oral. Many a times patients do not take these tablets, especially if it is given free of cost. They may sell also and make money. Malabsorption is another indication for parenteral iron therapy, and moderate to severe anemia, as I said, and just we have 4 to 6 weeks to go. Parenteral iron therapy is better because you can ensure that entire iron is calculated and given in a sitting. What are the options or prerequisites we have? Correct diagnosis is important because otherwise you will cause hemosiderosis. If you give parenteral iron therapy to a patient having beta thalassemia, it will cause more harm than good. And she has no allergy for the parenteral iron therapy. Nowadays, the preparations that we have are less allergic. However, it is prudent to give a test dose. Adequate supervision and facilities to manage adverse reactions. So it should not be given in an outpatient clinic. It should be preferably given in at least a daycare clinic or maybe in a place like Manipal, we usually give it in a HDU. Iron type is, there are several types. Best is iron sucrose and ferric carboxymaltose. That FCM has now become very popular. Dose calculation, there are many formulae. I've gone for the simplest one, 250 multiplied by deficit. Deficit is calculated by taking 11 as the cutoff and whatever hemoglobin the patient has. For example, if her hemoglobin is 8, 11 minus 8 is 3. So 3 into 250 is 750 plus 500 milligrams for the storage. So that's how you have to calculate. Injectable iron sucrose, if you use, it is 200 milligrams diluted in 200 ml of normal saline in 20 minutes per day, alternate days. So it's very simple. 200 milligrams in 200 ml, 200, 20 minutes per day and alternate days. Because why alternate days? This question will be asked. You need time for replenishment of the receptors. Otherwise, there will be wastage of the iron that you give daily. Whereas FCM, it is 1000 milligrams, again same 200 ml of normal saline, and again 20 minutes. It is per week, right? Again, alternate weeks you can give, again for the replenishment of the receptors. Now, this seems to be a better option. That is 1000 milligrams you can give in one sitting. Patient doesn't have to be admitted at all. Earlier, we used to admit the patients or we used to ask the patient to come alternate days. Both are difficult for the patient. This FCM, in a single day, you can give 1000 milligrams. Most of the calculations come around 1000. Like in the example that I gave you, 11 minus 8 is 3. 3 into 250 is 750. 750 plus 500 is 1250. That 1000, if you give FCM, remaining can be given maybe orally, or you can ask the patient to come next week, or you can give one iron sucrose after 1 week. So blood transfusion, of course, it's not blood transfusion, it is a blood product, PRBC transfusion usually. Severe anemia, irrespective of period of gestation. Moderate to severe anemia within 4 weeks of EDD. If it is refractory anemia, not responding to iron at all, or hemolytic type of anemia, where the RBCs are being destroyed, better to give fresh RBCs. Patient being taken off for cesarean section, you don't have any time to build up the hemoglobin. If it is less than 10, usually see that's why again another confusion. Diagnosis is 11, but for cesarean section, minimum requirement is 10, or for any procedure for that matter. So if it is less than 10, then you may give a PRBC and take her up and keep one more PRBC ready because should she have postpartum hemorrhage. What are the advantages of blood transfusion? As I told you, it's an instant rice. It's like instant coffee. 1 gram per DL per PRBC. That's a question again asked. So if you give 1 pint of PRBC, then it'll be increase of 1 gram per DL. It increases oxygen carrying capacity instantly. That is the most beautiful part of PRBC. It stimulates erythropoiesis. That's the added advantage of giving PRBC because later if you switch over to oral or elemental iron, so this will stimulate erythropoiesis by itself. Patient feels better instantly. You can see the dramatic change in the patient. The second part of management, I told you first part is treating the cause or treating the disease, that is anemia, over. Second part is prevention of complication, and third is obstetric management. Now, prevention of complication, the main complication is congestive cardiac failure. Avoid infections because anemia, severe anemia itself will put a load on the heart. On top of that, there is infection. It is extra load on the heart because heart has to oxygenate the blood more frequently. It has to pump more frequently. Undue exertion or stress, it is same as in case of a cardiac disease, and treat very aggressively other medical problems and cardiac failure and preterm labor promptly. The management of cardiac failure and preterm labor is there in another topic, so I don't want to go into details of that today. So the third management, obstetric management, this is the most important slide, and this is the most important chapter. In fact, I have to tell you a story. When we were asked to give a sample chapter, when I was being selected for the author of Holland and Bruce Obstetrics Manual, the chapter which I wrote was simplest chapter, obstetric decision making. It's a chapter number 99 also. And it's hardly 1.5 pages, but entire obstetrics is hidden in that. This is my unique chapter. This is my unique concept. So there are only 4 questions in obstetrics. I thought of so many things. There are no more questions. And these 4 questions are there irrespective of the type of obstetric case, whether it is anemia, heart disease, preeclampsia, diabetes, thyroid complicating pregnancy, malpresentation, anything you say, twins. So these are the only 4 questions. And the question number 1 is $1 million question. That's what I always say. When to deliver. One who knows when to deliver is the best obstetrician. And for that, you have to have a lot of knowledge. If you deliver too early, baby will suffer. If you deliver too late, mother will suffer. It is a tightrope walk. So, but for every question that I am posing, there is a default answer. Default answer means there's automatic answer unless the answer is rated by other factors. The default answer earlier in the chapter in fifth edition, I have fourth edition rather, I have given it as the 37 completed weeks, but I have revised now it as 39/0/7. This is a stylish way of writing. Why 39 weeks? Because the 37 to 39, according to modern definition, is considered as the early term, right? And these babies behave like late preterm. What is late preterm? 34 to 37. So 37 to 39 babies, which is called early term, they will behave like late preterm. That means there is still some incidence of RDS. Whereas after 39 completed weeks, there is absolutely no evidence to show that there can be RDS. Suppose, of course, there should not be any other problems. Now, exceptions to this rule would be preeclampsia, wherein we say 37 completed weeks is good enough. Otherwise, we are in trouble for both baby as well as mother. And sometimes unknown IUD in the past, which is happening around 37 weeks, you don't have to wait till 39 weeks. Otherwise, best is to wait for 39 completed weeks because the incidence of RDS is almost zero. I hope I'm very clear about that. The second question and the important question is how to deliver. Thank God. There are only two routes. One is abdominal route and vaginal route. So, but there can be a lot of debate on that. And if you are on any side, you will be burning your fingers. So, how to deliver? Of course, there's a default answer. Vaginal delivery is always preferred. And the third question, if you prefer a vaginal delivery, the next question comes up whether to wait for spontaneous onset of labor or whether to go for induction. So the default answer, again, better to wait for spontaneous onset of labor unless there are overriding factors which force you to induce, for example, again, preeclampsia. These are the easy examples. Then last question, only if you have decided to induce. Otherwise, this question doesn't arise at all. How to induce? There are only two methods again. The medical method, whether PGE1 or E2. Oxytocin, of course, is not a good inducing agent. The other one is surgical method, ARM, but usually ARM is followed by oxytocin. So these are the four questions. Take a screenshot of this. This is patented by me, right? So when to deliver, I have already told you, but earlier, if there are complications like imminent eclampsia, abruption, poor fetal Doppler, how to deliver vaginally, of course, I told you, cesarean is only for obstetric indications, fetal distress, or other indications which you know. There's a big list. Wait for spontaneous of labor, of course, yes, unless there are complications like preeclampsia, GDM, and others. And how to induce, I've already told you, depends upon the engagement of the head. If its head is engaged, only then you can think of ARM, especially if the cervix is favorable. If the cervix is not favorable, then prostaglandin gel followed by maybe misoprostol or just misoprostol. And then, of course, you can do ARM later. Favorable cervix is an important issue. Contraindication should be kept in mind. So let us try to adopt this general formula, which is not specific to anemia, into our anemia case. When to deliver in a case of anemia? Of course, after 37 completed weeks. The problem is these patients are more prone for preterm labor, so we have to really struggle to prevent that. How to deliver? Of course, vaginal delivery, unless there is a, CPD or, which is unlikely, or if the patient has a malpresentation or some other situation. Malpresentation happens in multigravida, and anemia is common in multigravida. Whether to wait for spontaneous of labor? Yes, of course, anemia is not an issue for induction as such. Maybe preeclampsia, yes. But then, of course, if you feel that the patient is crossing 40 weeks and nearing 41 weeks, then you may think of inducing labor. But that is very, very rare in anemia. Because again, I'm telling preterm labor is more common than not. How to induce? Question doesn't arise at all because preterm labor is more common. I'm telling this many, many times. Usually patients get into spontaneous labor in anemia. Of course, if there is a situation, you can go for PGE2 gel if it is tight, long cervix. Otherwise, misoprostol also can be used. What are the indications for cesarean section? Only obstetric indication. There's no medical indication. Anemia is not an indication for cesarean section at all. In fact, it is better to avoid that. Otherwise, there will be a lot of bleeding. CPD, major degree placenta previa, fetal indication like fetal distress. These are usual ones, malpresentation, not specific to anemia, right? Labor management, this is very important. This is somewhat like a case of cardiac disease, though it is not a cardiac disease, but the preparation and the management is almost same. Make sure that anti-failure drugs are available in the labor room. What are they? Please recall, I told you this in the cardiac disease class. Number one is oxygen. It is not by any acronym. Oxygen, I used to jokingly or very lightly tell the PGs, when you don't know what to do, please give oxygen. Whether it is a delivery case, whether it's a fantastic disease or anything. The name of the disease will be very big, but the answer is simple: oxygen. Pethidine, this is to alleviate the anxiety, pain, and other things. Digoxin to buck up the heart, and diuretics is to decrease the overload on the heart. This goes without saying. First stage, of course, patient should be in the bed throughout because there can be sudden precipitate labor. Inertia is more common in anemia than precipitate labor. Precipitate labor occurs if she is in a preterm labor. Why she should be in the bed, especially in the proper position, somewhat like cardiac disease, she should not be exerting herself, otherwise she'll go for failure. Proper position, that's what. Avoid IV fluids, again, like cardiac disease, afterload on the heart should be avoided. Pethidine 100 milligrams IM is given in active stage of labor. Otherwise, she'll go for retardation of the labor. Look for tachycardia more than 100, arrhythmias, which is bad. Basal crypts means she's already in failure. Second and third stage, Second stage, cut short by outlet forceps in vacuum. The only reason is you avoid exertion by the patient because in second stage she has to exert, isn't it? Active management of third stage of labor goes without saying, especially in case of anemia. 10 units of oxytocin IM, delivery of the anterior shoulder within 1 minute of the baby, and controlled contraction, especially after the signs of placental separations are seen. I always argue better to wait for that. You don't lose anything. Massaging the uterus, especially if you anticipate postpartum hemorrhage. What is the postnatal management? Close observation for development of infection, congestive cardiac failure, and DVT. These are the three main dreaded complications. Blood transfusion is avoided just to have rapid improvement. As long as the hemoglobin is more than 8, especially in the postnatal period, you would like to give either injectable or even oral. Patient should be discharged with appropriate contraceptive advice because she is already anemic, and if she has pregnancy, immediately she will go for more anemia. So a good contraceptive agent. Better would be a intrauterine device because that will decrease the menorrhagia also, especially LNG IUS. Yes, I am coming to contraceptions. For spacing, COC or LNG IUS, both are okay. Copper T is relatively contraindicated. Nowadays, we don't use copper T as such unless it is given free by the government of India. Permanent methods are polymerized sterilization. This is for gravida 2, para 2 onwards. And now I come to the other types of anemia, megaloblastic anemia. It's a derangement of red cell maturation, not actually the decrease in the number due to impaired DNA synthesis. That means you have seen the DNA synthesis process in the earlier slide yesterday. So you require vitamin C, vitamin B12, vitamin folic acid, and all this, thiamine, everything. So if there is a problem there, there will be derangement in the red cell maturation. What are the causes? As I already mentioned, vitamin B12 and or folic acid. Malabsorption syndrome, Addison's disease, incidence is 0.5 to 3%. But usually it is seen with IDA because in IDA also there will be vitamin folic acid deficiency. So this will be called dimorphic anemia. There can be a short note. Dimorphic anemia means both type of morphologies are seen. What are the both types? Microcytic hypochromic, macrocytic hypochromic. That is both megaloblastic and the microcytic anemia. 5 times more in multi, 8 times more in twins. Clinical features, it is insidious in onset compared to other types of anemia. Of course, anemia due to IDA is also insidious in onset. Only the anemia due to hemorrhage or hemolysis is very drastic. It is usually seen in third trimester because of a prolonged deficiency. Patient will also have anorexia, protracted vomiting, diarrhea. The signs being pallor, glossitis in addition to pallor because of the vitamin B complex deficiency. Hemorrhagic patches under the skin and conjunctiva. Hepatosplenomegaly may be present. Peripheral smear is very typical, unmistakable, macrocytic hyperchromic. I'm telling it the third time. Anisocytosis, giant polymorphs, megaloblastic anemia name comes from that megaloblast. You know, always the initial ones are big cells, and when they mature, they become small. Unlike when we mature, we become bigger and bigger, hopefully. Hypersegmentation of neutrophils, Howell Jolly bodies. Of course, this we leave it to the pathologists and we trust them totally. If they say megaloblastic anemia, that's it. I don't want to look into all these things. Other lab values, serum folate is always less, 2.5 nanograms and less than that. Serum vitamin B12 is less than 90. Especially pure vegans will have this problem. And food-wise, you can't do much, so better to give injectable vitamin B12. MCV is more than 100 megaloblast. MCHC and serum iron are normal. That is the picture. Treatment, prophylactic folic acid 350 microgram or to 1 milligram per day. Curative is folic acid 5 milligrams to 15 milligrams per day. Vitamin C, vitamin B12 100 grams per day in injectable form. I was talking about dimorphic anemia. It's a very easy slide for me or very easy answer in the exam. Just mix the two. Commonest among the underprivileged because of all the deficiencies, dietary inadequacies, and malabsorption. Peripheral smear is mixed picture, both microcytic hypochromic, macrocytic hypochromic. Bone marrow, megaloblasts are seen. Treatment, iron, folic acid, vitamin C, vitamin B12. Anyway, even for IDA, you will give all these things. What is refractory anemia? One slide again for that. No adequate response to iron therapy. It is only response to iron therapy, then it is called refractory anemia. Because anemia will definitely respond to PRBC. Decrease in erythropoiesis and increase in destruction is one of the causes due to chronic diseases like chronic renal disease, inflammatory bowel syndrome, and granulomatous infections, malignant neoplasms, rheumatoid arthritis, SLE, suppuration. What's the treatment? Of course, blood transfusion or PRBC transfusion. Now, I did with the main causes of anemia, that is iron deficiency and megaloblastic anemia and dimorphic anemia, refractory anemia, physiological anemia. Now I come to anemia due to hemoglobinopathies. Before we go there, we need to understand the hemoglobin. That's why this slide is dedicated for that. Let's go slowly and carefully. Hemoglobin has 4 heme molecules plus 4 globin molecules. Now, these 4 globin molecules are 4 polypeptides chains: alpha, beta, gamma, and delta. Simple so far. Adult hemoglobin will have 1 pair of alpha and 1 pair of beta each. 95% of our hemoglobin is adult hemoglobin. Whereas there is another variety in adult, HbA2, where there will be alpha instead of beta. Okay, so that's the only difference. In fetal hemoglobin, gamma instead of beta. In A2, all will be alpha. Here it is gamma, 2 alpha, alpha and beta chain. So alpha chain and gamma chain. Whereas in the A2, it will be all alpha. These are less than 5%. Hemoglobinopathies are nothing but specific biochemical disorders in polypeptide chain, nothing to do with heme. Okay, it's polypeptide chain. Let's take up one by one. Sickle cell disease is nothing but it's an inherited problem where there's a structural abnormality involving primarily beta chain, not alpha chain. It is common among Africans. 2 abnormal hemoglobins are there in this, HbS, which is common, and HbC. We are getting new names, okay? HbS, HbC, we already saw HbF and HbA2. There is again homozygous and heterozygous. Homozygous means there are 2 S, genetically inherited, transmitted equally by male and female. Whereas heterozygous is one is A, other one is S. 25% of them. No clinical manifestation, but they are carriers, obviously. What are the characteristics of a red cell? The name suggests sickle-shaped cells. That's why the name comes sickle cell anemia. They are more rigid. They are not discoid type of beautiful, malleable red blood cells. They are more rigid ones, and that's why they don't pass through easily. Unable to pass through the microcirculation, there will be vascular occlusion. Whenever there is vascular occlusion, there will be problem, anoxia or hypoxia. They are more fragile. They break easily. Hemolysis is common. They have a shorter life compared to normal RBCs, which is 120 days. There is increased destruction. What is the result? Anemia plus jaundice. Why jaundice? Because of hemolysis. How do you diagnose? Of course, it's a refractory type of anemia, hypochromic, not responding to iron therapy, because most of the places we don't straight away go for electrophoresis. We always try with hemoglobin improvement by iron therapy. When it is not responding, we have to think of this. But sometimes in endemic areas, we have to straight away go for electrophoresis. Sickling test is done, but nobody does this these days. Persistent reticulocytes, high fasting serum iron, which clearly tells loudly that there is no iron issue. The issue is that of a structural problem with beta moiety. Electrophoresis is the way to diagnose. Effects on pregnancy, of course, like any other anemia, this is more so abortion, preterm delivery, IUGR, and IUD, PPH and infection, and sepsis. What is sickle cell crisis? Can be a short note sometimes. It is a hemolytic crisis due to hemolysis, rapid development of anemia as well as jaundice. There's one more crisis called painful crisis. The first one is hemolysis and jaundice. That's why it's called hemolytic crisis. Second one is painful crisis. You can easily guess why there is pain. It is ischemic pain due to vascular occlusion of various organs by capillary thrombosis, resulting in infarction. It's almost similar to the myocardial infarction type of pain. And abdominal and chest pain is very common, cramps, because if there's a blockage of the mesenteric vessels, it will be excruciating pain. Vomiting and hematemesis are very common. Hematuria is also known. How do you manage this? Antenatally, prophylactic folic acid, of course, that goes without saying. And because that is important even for nucleic acid, formation. Treat infection. So this is a secondary management. The main management is, of course, PRBC. Unusual symptoms by hospitalization, PRBC transfusion if the hemoglobin is less than 8 grams. Otherwise, these patients who keep, transfusing blood. So as long as they are 8, they can manage. Just before delivery, maybe you can give 2 PRBCs. Otherwise, they will have repeated transfusions. That itself will have problems. Place of termination, cordocentesis showing homozygous state. Otherwise, no need. Labor management, continuous oxygen, because there will be hypoxia, there will be otherwise the ischemic crisis. Avoid anoxia during anesthesia. Start antibiotics. Management of sickle cell crisis is oxygen again. Injection morphine pethidine to alleviate the pain. IV hydration for easy flow of the cells to maintain blood volume, and prophylactic red cell transfusion. After sickle cell anemia, the other major one is thalassemia. It's not very common in our areas, but it is common. Next to Manipal, we have Kerala state. There it is common. And other hilly areas also it is very common. In Malaysia also it was very common. Inherited defect in synthesis and production. There it was structure. Here there is problem of synthesis and production of globin itself. Alpha thalassemia seen in Southeast Asia and China, as I was telling in Malaysia. Beta thalassemia is more often seen in Mediterranean places. Homozygous means both partners again or parents. Heterozygous means one of the parents, other one is the carrier. Beta thalassemia is the common one in that we have major where there is homozygous genetic defect, progressive hepatosplenomegaly, that's how it is known. Intercurrent infection is very common, even bossing of the forehead also is seen. Whereas in thalassemia minor, it is heterozygous genetically. Not a very serious condition. There will be both hemoglobin adult A and hemoglobin fetal F. Sickle cell trait may coexist. Usually these are genetic problems, so there will be mixture of thalassemia and sickle cell disease. What is the hematological picture? Features of hemolysis will be seen. These are all very fragile type of RBCs. They break easily. Serum iron and SIBC are normal. That is the bottom line, in fact. And increased serum bilirubin because of hemolysis. Abnormal hemoglobin in electrophoresis, that is the mainstay of diagnosis. Management, folic acid throughout, that is again for the formation of the nucleic acid, not for hemoglobin. No iron, this can lead to hemochromatosis, hemochromatosis. So you will be doing more harm. So you have to give only blood transfusion if there is loss. Better avoid it because, as I said, many times you have to give blood transfusion. Up to 8 grams you can ignore. After that, you have to give PRBCs, as it may precipitate aplastic anemia. Thank you so much. I hope I have now fulfilled all your requests. Anemia, very important topic. I wish you all the best in the exams if you get it.